Welcome to the Center for the Study of Social Policy's Perspectives on Early Relational Health series. In the second session, we discuss creating a paradigm shift in pediatrics that moves us from responding to toxic stress to promoting early relational health.
Good day, everyone. It's a delight to be able to spend some time talking with you today, together with my good friend and colleague, Dr. Andy Garner. My name is Dr. Dipesh Navsaria. I'm a pediatrician at the University of Wisconsin in Madison, and I do a lot of work around thinking about children, families, and relationships between them. Andy.
And I'm Andy Garner. It's always great to talk with you, Dipesh. I am a primary care pediatrician in Cleveland. I also have a background in developmental neuroscience, and I'm one of the co-authors of the American Academy of Pediatrics' recently revised policy statement on preventing childhood toxic stress.
So speaking of that toxic stress policy statement, the very first lines I think are just absolutely essential and tremendous in terms of the implications they have. It begins with, by focusing on the safe, stable, and nurturing relationships, those SSNRs, as you call them, that buffer adversity and build resilience, pediatric care is on the cusp of a paradigm shift that could reprioritize clinical activities, rewrite research agendas, and realign our collective advocacy. Wow, right? There's a lot packed in there. So can you talk a bit about the implications of that, not just for what you and I do when we're in the clinic, but really for thinking about how broadly as a society we help children and families think about relationships?
Sure, and we put that right up front because I think it really gets at the heart of what we were trying to do with the policy statement. We're trying to acknowledge that it's really important for us to acknowledge deficit-based models like toxic stress and adverse child experiences. And to be honest with you, most of contemporary medicine, as we've talked about before between the two of us, medicine is very much a deficits-based model. But try and pivoting from that towards a strengths-based models, things like relational health and the safe, stable, nurturing relationships and positive childhood experiences. And to a certain extent, that's what pediatrics has always sort of intuitively been about in the first place, right? To focus on building relationships. So this pivoting, it's sort of like taking on a different lens, because when you use a different lens, everything changes, right? And so it really is transformational in the sense that it's getting us to have very different priorities that sort of come into focus with this different lens. So at a clinical level, what we've learned is that it's really not enough just to prevent adversity and toxic stress, right? We also need to proactively build those relational contexts that kids need to be well, to be resilient, and to thrive. So that's a huge clinical lift right there. In the research side of things, there's a lot of emphasis on sort of identifying clinic-friendly biomarkers, not only to identify those at risk, but also to begin quantifying the buffering effects of relational health. But I think even more than that, we want clinic-friendly measures that look at a dyadic dance and the degree to which we can actually sort of promote this thing called biobehavioral synchrony, or autonomic emotional connection, which is sort of the fancy ways of talking about that connection when you're in sync with someone and you're really connecting on an emotional level. We need better measures of that. And then for our advocacy, and this is just huge because, it needs to be too generational, right? So, we want to try and help the parents and caregivers in order to help the kids. It's important for funding because we need more team-based care and really sort of redesign primary care as our anticipatory guidance that we all use needs to focus on different things, right? We need to help parents regulate and then relate and then reason in order to sort of build new skills.
So I love how you've taken something that I think so many of us observe when we're looking at families together, right? Those beautiful moments of responsiveness, of nurture, of really connection, of being in tune with one another. And you've put a really wonderful name to it, right? That interactive dance, but also that biobehavioral synchrony is the term you used and all. So let's unpack this, right? Like when working with a family, whether it's us as pediatricians or whether it's home visitors or community health workers or psychologists, whoever it may be that touches those families' lives, how does this look, right? How should someone start if they say, I want to make sure I'm supporting this, right? What's the first thing they should do when they sit down with a family, say their hellos? What happens?
So I think it begins with this concept of parallel process, which would be very familiar to people that do home visiting and community health workers. Decided that how we treat families and parents and caregivers, it's going to be mirrored in the way that they hopefully then treat their children. And so we want to try and motivate them to make that dance, to make that connection a priority, by modeling the way we interact with them, by active listening and motivational interviewing and those sorts of things. But I think this word motivation is a tricky one, because I think we have to be very careful not to be too condescending or prescriptive or sort of culturally inappropriate. I think I love the framework that's out there called self-determination theory, right? So self-determination theory is that there's, external motivations, what you say, what I say, and then there's intrinsic motivation. And all parents are sort of intrinsically motivated to connect with their kids. We know that's a biological thing that happens early on. But self-determination theory says that intrinsic motivation to try and motivate people to do things comes from autonomy, competence, and connection. And so for me, it all starts with connection, right? It starts with the way we're connecting with those families. And so we want to have active listening, right? Which is why the EMRs, you and I both have talked about this before, make us crazy, because we're focusing on typing and documenting instead of actually
electronic records.
Oh, makes you crazy. And so we want to meet the caregiver needs too, right? Because that's telling them we're meeting you where you are. We care about you. So it starts with that connection. And then we also want to build connection by noting competencies, which is basically what we always tell parents to do to kids, right? Catch them being good. So notice the effort that they're making, and that in turn that will not only build the connection, but also then motivates them to keep doing those positive things. And then we want to try and tap into autonomy wherever we can, right? Because as soon as we say, well, why don't you cut the autonomy? And so it really needs to be what they want to do, what they think might help, and what their passions are, and noting the fact that they're enjoying that shared reading, they're enjoying that play. We want to reinforce that as best we can.
There's so much, as always, there's so much wrapped up in the implications of what you're saying here. I like how you're, setting this almost like leveling the playing field in a sense, right? It's so easy when you do this kind of work to kind of fall into this tendency of, oh, let me just come in and let me dispense advice, right? Here, I've now told you the magic things about parenting, and now I'm just going to disappear. But what's really, what you're saying very clearly is, like, not only should we be engaging with families, but we should be looking for their strengths, and that we should be recognizing that they're the experts in their individual child, right? You and I have the benefit of having seen thousands of children, but we don't know all that much about any one individual child. And for the parent, it's flipped. They know their child, and one presumes they haven't had thousands of children, so it really changes up things. And this idea of this listening and observing. Okay, I'm going to throw a Ted Lasso quote in here, right? Don't be judgmental, be curious.
Absolutely,
that's what it comes down to, right?
Yes. Oh, there's no question. And even more than that, I think it's empathy, right? I mean, I think that is that's the magic ingredient there. Again, whether you're talking about an autonomic emotional connection, whether you're talking about biobehavioral synchrony, it has to start with empathy. It has to start with willing to connect and be vulnerable. And I think that in many ways is sort of countercultural right now. I think in a million different ways, we let children and families and other people know that empathy is somehow a weakness. And I spend a lot of time in my clinic talking about Frozen, the movie Frozen, because Frozen, I think, is a good analogy where, this princess thought that she had to hide something with some horrible secret that she had to be ashamed of, when in reality it was a superpower. She just needed to know how to control it. And I think that's the same issue with empathy and strong emotions that people are overwhelmed with right now. And I think that's part of the issue for the providers is it's very easy to to see that empathy as being a weakness, that we're hearing all this vicarious trauma. We're encouraging providers to dig deep into that emotional content, to emotional traumas that have happened in the past, to ACEs, social determinants of health, all these heavy burdens. We're asking providers to try and ask these questions to try and help. But if we can't learn to control that empathy, then it leads to burnout, right? And so I think that most people that are in child-facing and family-facing professions are there because they want to help. They're empathic people, and that's a good thing. But we also have to learn to control it. And so I think that by throwing everyone in and saying you need to focus on relational health, you need to dig deep into these things without helping them understand that, again, Bruce Perry likes to talk about the process where you need to regulate, relate, and then reason. And so reasoning is where we want to get at. We want to build skills for the child, for the family. We want them to be in their thinking and learning brains. But to get there, we have to go upstream a little bit and help them to relate, because through biobehavioral synchrony and an emotional connection, we can help them get into the thinking brain and out of the survival brain. But we have to go up a little bit straight from that, because in order to relate, then we also have to regulate, right? Sure. We have to be empathic, because if we're doing biobehavioral synchrony and we're not in our relational brain, then we're making matters worse. And so I think that's the way I think about it.
Yeah. So what I hear you saying is that some of these tendencies we have to, on one hand, sometimes we distance ourselves, to the point that's not helpful, but it's also possible to get so almost enmeshed in what's going on that we forget to regulate ourselves. So there's two sides of that there. And at some point, you just had to learn to let it go. See what I did there?
Well, I think that's it. I mean, I think I like Bruce Perry's, the sort of model in the sense of regulate first, right? Because, whether it's the caregiver or us as providers, if we're not regulated, then we're not going to make any progress. Then if we're regulated, then we can relate on an emotional level and have that connection. And once we have that connection, then we're in a process where we can actually begin building new skills, thinking about things in a different way, learning new approaches to difficulties.
So I want to transition a bit here to really thinking about what's really different in the second edition of the toxic stress policy statement, because the first one really articulated beautifully about these concepts of toxic stress, of adverse childhood experiences, and so on. But the second one is really about prevention, about looking for the strengths, for the positive childhood experiences. And a quote that you've used that I think really encapsulates it beautifully is, preventing toxic stress and promoting early relational health are two sides of the same coin. Can you say a little bit more about that paradigm shift between the first and second editions?
Sure. Well, I mean, I think toxic stress by definition sort of occurs when there is significant adversity in the absence of the safe, stable, nurturing relationships that allow the body's stress response to quickly return to baseline. And then relational health by definition sort of refers to the ability to develop and sustain those safe, stable, and nurturing relationships that not only buffer adversity, but also practically build the skills needed to be resilient and to thrive. So they're both important frames to consider, but they're sort of two sides of the same coin, in the sense that one's what's happening in the absence of relational health, and the other is what's happening in the presence of relational health. So again, I think in the midst of a pandemic and a reckoning with racial inequality, the toxic stress frame has never been more relevant, right? Because it explains how many of our society's most intractable problems, again, disparities in health and education and economic stability, they're really rooted in our shared biology, but our divergent experiences and opportunities. Whereas relational health explains how those individual, family, and community capacities that support the development and maintenance of those safe, stable, nurturing relationships, they also buffer diversity and build resilience across the life course. So again, it's sort of, it's not that one's necessarily better than the other. We need both. I mean, the idea that we don't need trauma-informed care, that's not what we're saying. What we are saying, though, is that just having trauma-informed care and addressing ACEs and toxic stress is not enough. Sure. That's important. But if we really want kids to reach their full potential and to thrive and to be resilient, we also need to have the good stuff. We got to have the positive childhood experiences that come from the safe, stable, and nurturing relationships, that relational context that allows kids to develop their full capacities.
Exactly. So while you and I are waiting for that magical time in which we feel like we have all the time we need with each and every family to not only address their needs, but to explore their strengths, one of the things we do is we rely a lot on an awful lot of other people, particularly who are more based in the community outside of the walls of our hospitals and clinics, community health workers, doulas, home visitors, early childhood teachers, dietitians, you name it, right? How can they help us with thinking about all these and be part of our team and part of the group that's really rooting for the success of all the families that are out there?
Well, I think it's absolutely critical. I mean, I referenced earlier that we need team-based care in our advocacy, right? I mean, as good as you are, you can't do it all, and so we need to have a team-based care. And I think we got into this in the policy statement as well, that there's not going to be a single magic bullet here. We need layered interventions, and we talk about sort of a public health approach that layered vertically in terms of layering on interventions, but then also horizontally across sectors. And I think that's what we're sort of getting at here, is that it's not something that's going to happen just in the pediatric medical home or our doctor's offices. It's something that really is a much bigger issue. It's really sort of a cultural change. So to specifically answer your questions, what can these other workers do? Well, certainly we can identify barriers to relational health, right? So we want to identify the social determinants of health when they exist, the early relational trauma and parental ACEs, and really a 2-generational perspective, right? Because again, we have to try to find a way to help the caregivers and the parents regulate by identifying those barriers. We want to use, I think, developmental milestones to sort of support advance in a proactive manner, and that's tapping into the wisdom of Brazelton and touch points, right, to try to build that biobehavioral synchrony. So we want to make it to say that it's good to have shared reading, preaching to the choir here, but also
read, yes.
developmentally appropriate play. Any sort of developmentally appropriate play, right, is a really important way of building that connections and building that synchrony. And then once all of us providers have established that safe sort of non-judgmental therapeutic alliance, then we're in a better position to reason and to partner and to hopefully tap into that intrinsic motivation that's there anyway, to do those sorts of things, to use the play and to use the shared reading. So I think that, we tend to think about relational health as being very dyadic and being the caregiver and the child. And it certainly starts there, but I think we need to be aware that there are sort of ecological spheres of relational health around that directly impact that relational health, right? So, if there are familiar troubles, so there's relational trauma, there's intimate partner violence, there's mental illness, there's substance abuse, that's going to, in a family sphere, that's going to hinder relational health at the dyadic level. But if there are family resilience and connection, well, that's going to promote it, right? And then if we move a little further and start thinking about what's happening at the neighborhood level, if there's unstable housing and there's neighborhood violence, well, that's going to impact the relational health at dyadic level. But if there are safe places to learn and play, that's going to promote that dyadic level relational health. And then even at the level of employment, if we have discrimination and we have unemployment, that may impact in a negative way the dyadic relational health. But if there are opportunities for growth and livable wages, that may promote it. And then even as we interact each other as strangers, if there are microaggressions that may hinder relational health at the dyadic level, but there's kindness that may promote it. Again, that empathy I was talking about before. And then even sort of at the bigger societal level, if we have structural isolation and or rather social isolation and structural racism, that's going to hinder the relational health to a certain level at the dyadic level. But if we're having, social inclusion and diversity is valued, then that's going to try and promote that relational health. So I think that's not something that you and I or any individual clinic can do. That's going to require a team approach. That's going to require a whole cadre of community health workers and doulas and advocates to really sort of change sort of, again, the culture. And that's a much bigger issue than you and I are going to be able to tackle.
It's the relational village, right? It literally takes a village.
Yeah.
Well, we are about out of time here. So in closing, is there some way that you have to sum this up? What's the one thing that you'd like to leave our listeners with?
Well, I think I mentioned it before. I think that in many ways this is countercultural, right? I think that empathy is a superpower, and I spend most of my time that I'm privileged to have with families talking about what their passions are, even at a young age. You know, what do you love to do? What are you doing on a rainy day? You know, because I want to tap into their autonomy. I want to tap into their passions, and if I can find those things that they love to do, then that's the hook that I can use to really start talking about emotional intelligence, that there's nothing wrong with strong emotions. And if you feel things strongly, that's great. That's more energy. We can help you channel that into a passion. You're gonna be really good at something. I think that, there are very few places that we actually have the space, or rather make the space to talk about our emotions, to proactively build healthy responses to strong emotions. And with the pandemic and social isolation and racism, there are a lot of strong emotions right now. And so I think the more we spend time talking with families and children that it's okay to have those strong emotions. I mean, don't ignore them, don't suppress them. That's part of being human. You can't have the good stuff without the bad stuff. And so how do we learn to adapt with that? And I spend a lot of time talking about passions and using those as healthy ways. So now I'm proactively building resilience instead of hoping they're going to figure it out.
Yeah, really, how do we normalize talking about emotions,
Yeah.
hopes, dreams? One thing I started doing years ago was at every 4-month well child check, I'd look at families and ask them what their hopes and dreams were for what their child would be like in 20 years. And the moment of surprise and then this delight that you'd see as parents would talk about that, because no one asked them that in this world of healthcare. So for me, my one of my big takeaways, it actually goes back to something you said a few moments ago. There's the wonderful Yuri Bronfenbrenner quote, which is also featured in the policy statement, which I'm paraphrasing, that talks about how every child needs, at the very least, at least one caring, loving adult that is absolutely crazy about them, that's just nuts about them, right?
Yeah.
And I always say, and there's one little addition I'd make to that wonderful quote of Bronfenbrenner's, which is, not only do they need that one adult that's nuts about them, but that adult has to be able to show it, right?
Yeah.
That there needs to be all those enabling factors, right? Stable employment, appropriate mental health,
Right.
feeling confident and competent in parenting skills, et cetera, et cetera. And that's really what we're building out here, right? Is how do we make it not just about the dyad, but also do we make these larger environments, whether it's the family, the neighborhood, the community, or society, be one that is truly that relational village that we talked about.
Amen.
There you go. Andy, as always, it's a delight to spend time chatting with you. Thank you.
Agreed.